Today, and the least important person in the entire session. This session, of course, is about caring for Ebola and lessons from the front lines. And so we have a couple of experienced clinicians who have cared for patients with Ebola virus disease. We're going to start very quickly with a person that I have known for a really long time, ever since he was a third-year medical student and I was his supervising resident. His name is Gary Weinstein. He's located at Texas Health Presbyterian Hospital, where he is the Chief of Intensive Care Services and Chief of Pulmonary. I think it's all listed up there. So we asked Gary if he would talk about this, because if you want to stop and think for a second what it might be like, we all kind of heard about Ebola in Africa. We all knew that, yeah, there was a chance that someday it might make it to the United States. And we all probably never, ever thought that it would be at our front door at our hospital. And I think that applies to Gary as well, if I'm not mistaken. But it did. It happened. It showed up. And someone had to be the first place to be a community hospital, not a specialized Ebola treatment center or a specialized communicable diseases center, but the first general hospital to encounter a patient with Ebola virus disease in the United States. And so we invited Gary to come and talk to us about that, and he's got a lot of good things to say because I've been on the phone with him a lot lately. So Gary, we can all see you, and it's really good to have you, and you go ahead and take it away.
Great. Well, I very much appreciate the opportunity to speak at this conference, and I think that sharing the information that we've gathered, in my mind, is probably one of the most important things I'm going to be able to do in my career. My talk is obviously about Ebola, and this is not just the United States experience, but this is the Dallas experience. Hopefully no one will ever have this same experience that we did. But this is our story, and I'm sticking to it. I have a couple disclosures. I am on the Speakers Bureau for GSK, Pfizer, and Boston Scientific. I also thought it was important to disclose that I am a Jayhawk. I got my undergrad at University of Kansas, got my medical degree, and did my internal medicine training. And from there, I went to University of Texas Southwestern at Parkland, where I did my pulmonary and critical care training, and I've been at Presbyterian Hospital ever since. Sorry about that. If you have questions, you can tweet them, and we will do our best to answer them after both of us have spoken. Do hashtag Ebola chest. And what I want to talk to you about this afternoon is a journey. And I think everybody's pretty familiar with the journey that Mr. Duncan took from Liberia to Brussels, to Washington, D.C., to Dallas, and to my hospital. But we also had a journey, and our journey is continuing. There's been a bunch of analogies. We are ground zero for the United States. The second one is one that is a little bit more meaningful to me. We were on the front row in the first car of a speeding roller coaster that had never been built and run before. And as you can imagine, it was somewhat of a wild ride. I want to tell you our perspective of who we are. I think a lot of people have heard a lot on the press, but this is who we really are. We're a private, not-for-profit, community teaching hospital, not associated with the university. We're part of a large corporation called Texas Health Resources. My hospital is on a 78-acre campus with over 1 million square feet of space, 898 acute care beds, 3,300 employees, greater than 1,200 physicians on staff. Our emergency room has over 80,000 visits per year, and we have more than 27,000 admissions per year. Our nurses have magnet designation, and we have a medical ICU, surgical ICU, and a trauma ICU that has just opened. I want to briefly overview Ebola virus disease, or EVD. As I'm sure all in the room know, this is previously known as Ebola hemorrhagic fever, and it can cause disease in both humans and non-human primates. The natural reservoir host of Ebola isn't known. It's thought to be animal-borne, and it's suspected that it's bats. Cases to date, as of yesterday, 10,114 cases with 4,912 deaths worldwide. In the United States, 4 cases with 1 death. There is no established FDA-approved treatment. Supportive care, aggressive supportive care is the standard of care. There is limited experience in what's been termed resource-rich environments, and patients present with very nonspecific symptoms. With differential, that's malaria, typhoid, cholera, other viral illnesses. Up until about a month ago, there was a pretty low index of suspicion in the United States. Now, not so much. The clinical course typically has 2 phases. A prodromal phase, which happens in the first 1 to 4 days, with fever, chills, myalgia, and malaise. Typically, patients have leukopenia, thrombocytopenia, and elevated LFTs. And the second phase is the acute phase, which happens days 4 plus, typically characterized by severe watery diarrhea with liters and liters per day, along with nausea, vomiting, and abdominal pain, headache, chest pain, shortness of breath, and a rash. And patients can develop coagulopathy, expected electrolyte abnormalities from their vomiting and diarrhea, as well as metabolic acidosis. It can continue to progress to multi-system organ failure with shock, respiratory failure, renal failure, encephalopathy, and hemorrhage. What did we do? How did we spring into action when Mr. Duncan was admitted to our hospital? Again, this is what really happened. An Ebola task force was formed on the 30th of September when the diagnosis was first established. That included key hospital personnel, both on the medical staff as well as in our administration. We had our first incident command center meeting the next morning at 7 in the morning with a large group of clinicians and epidemiologists from the CDC who had arrived the night before. We reviewed and updated our policies and protocols with the CDC on a regular basis throughout this process. And also on the 1st of October, we had our first clinical conference with the CDC and clinicians from Emory. And we had that at least once a day at 4 o'clock in the afternoon, where we discussed our current patients, their experience, their advice, and any tips they could give us and feedback. It was very, very helpful. This is, again, just to show what was really going on. We did change some of our equipment along the way. We started with the first type of PPE hood on the left, which did not have the shroud. And we ended up, after further consultation with some nurses from Emory who came to help us, switching to the other hood. with the shroud. I'm going to briefly review our three patients. Patient number 1 was a 45-year-old Liberian male who presented with a 4-day history of fever, headache, and a 2-day history of diarrhea. On admission, he had a fever to 103, a white count of 3.13, platelets of 68,000, elevated LFTs, and his cycle threshold, which, if you're not familiar with that, which I was not until I encountered Ebola, is an indirect measure or an inverse measure of a patient's viral load. The lower the number, the more virus there is. A value of 19 is a pretty high viral load. When they do these measurements, when your cycle threshold is over 40, you're considered to be virus-free. A PIC was placed for access and monitoring. He slowly, over the next several days, developed some mild hypoxemia and azotemia. Midway through his course, he developed hypotension, which was treated empirically as adrenal insufficiency since we were unable to check those labs, which I'll explain a little bit more in a moment. On hospital day 6, he required intubation for hypoxemic respiratory failure, and CVVHD was initiated after a dialysis catheter was placed because of progressive renal failure. His cycle threshold actually fell initially, which means he had a greater viral load, and then continued to improve, which means his viral load was decreasing. And in spite of that, he died on hospital day number 10. Patient 2 is a 26-year-old nurse who presented with a 1-day history of fever, chills, headache, and a mild sore throat. She presented approximately 11 days after her initial care of patient number 1. Again, a PIC was placed for access and monitoring. On admission, she had a low-grade fever, leukopenia. Her initial platelets were normal, and she had mild LFT abnormalities. On day 2 to 3, she developed a mild, nonspecific macular papular rash that was non-pruritic. Her labs, right count natered at 2, platelets at 63,000, and her LFTs maxed in the 200s. Her cycle threshold, which was initially 32, climbed to 36 and then to 38. And as I mentioned, if it was over 40, that's considered virus-free. She was transferred to the NIH on hospital day number 6. Patient 3 presented with a 1-day history of fever, approximately 14 days after her initial care of patient number 1. A PIC was placed for access and monitoring. You can see her admission vitals. She was tachycardic, that we felt to be due to volume depletion, and she had leukopenia, thrombocytopenia, and more elevated LFTs. Her cycle threshold was 30 and improved to 33 the following day, and she was transferred to Emory on hospital day number 2. The management considerations that we embraced and that we discussed with our colleagues from Emory and the CDC involved aggressive supportive care, as has been the recommendation by all. Early central access, which makes drawing labs less risky for the staff and more comfortable for the patient. It allowed us to do central venous pressure monitoring as part of our evaluation for their volume status. We used the general principles of critical care medicine, including early goal-directed therapy, but we did attempt to avoid hypervolemia, and there was some discussions and recommendations to use colloid versus crystalloid early on. You have to use early empiric antibiotics because blood cultures cannot be obtained safely. Nutritional support is important, and TPN should be considered if the patient cannot tolerate or keep down enteral nutrition, which is certainly difficult during the severe diarrhea phase. For those patients who develop ARDS, we use, again, the same principles we use every day. Lung protective strategy. And we did use renal replacement therapy in one of our patients, and that has been done in one of the patients in Emory. There's some special considerations that make this quite a bit, taking care of these patients quite a bit more difficult than our typical ICU patient. You can't get blood cultures or urine cultures, any cultures. The risks of the lab as they plate things out and open the petri dish and try and grow cultures and analyze what's growing in the culture is too high. It's important to get from your lab manager, your lab director, a list of no labs. There are some labs that they just won't do because the risk to the lab personnel is too high. And depending on your lab equipment, there are some maybe labs. We have dual equipment in our lab, and we did not run these lab samples first thing in the morning like we did do the rest of our ICU patients, because once a sample was run in the machine where it could be analyzed in a closed system, the machine then had to be shut down for 2 hours while it was disinfected. You have limited imaging. You can do imaging that comes to the patient, but you really don't want to send these patients down to the radiology department. You have to think about how to control human waste, and by that I mean patients who are able to control their body fluids and use the toilet should be allowed to do so. Patients who are not able to control their body fluids need to have them controlled with collection systems, a Foley catheter, a fecal containment system. And then you have to also handle all the waste that's been produced. There's human waste, there's non-human waste, and it is all considered highly infectious and needs to be handled appropriately. You have to think about and hope you don't need a patient with Ebola who might need urgent or emergent surgery. We did not have up front, but developed pretty rapidly, a small team of surgeons and anesthesiologists who were willing to go into a room and do a procedure that needed to be done if they could do it in the hospital room. These are not patients that we would want to take to the main operating suite and down the halls of the hospital. I want to walk you through visually how we converted one of our 25-bed ICUs into a 3-bed Ebola isolation unit. And again, the purpose of this is not to say this is the right way to do it. This is how we did it based on the layout of our ICU, because obviously our ICU was what it was, and we had to figure out how to make it work. And we had lots of help from the CDC, as well as I mentioned, a couple of nurses who came up from Emory to help us. We converted a family waiting room on one end of the hall into a donning area. You would come and grab your disposable scrubs, go into the bathroom, change out of everything, and come back in just your disposable scrubs, and then go through the steps of donning, using a checklist, using Observer, a mirror in the room, to make sure that you don appropriately. On the right is one end of our hallway. This used to be an open hallway down one side of our ICU. A temporary wall was placed with the zippered door, and once you were completely donned, you'd knock on the wall, and the person in the anteroom would open up the zipper, let you in, and assist you with your PAPR placement. This is just on the other side of that wall. The picture on the far left is looking down the hallway. The arrows on the floor are to remind us about one-way flow. You want to make sure that you go from the clean area and into the dirty area and then out and not come back. On the right of that picture are patient rooms. The middle picture just shows a mirror that we had. It was one last check for you to look yourself to make sure that everything was covered, that your PAPR was placed correctly and nothing was exposed. And the picture on the far right is just one of our X-ray machines, our portable X-ray machines, that came into the hot zone and then stayed there, not to be used in general circulation. This is at the opposite end of the hall. When you finish seeing your patients, the picture on the far left is one of our ICU rooms that had a shower in it that was split in two with a large plastic sheet. At the far end of it is a zipper to get out into the other side. Just inside that room, the middle picture is where you would, after you'd completely doffed, you would then place your shoes into the pan with a virus or viricide in it. Take off your disposable scrubs. Everything's in the red bag trash, and then there was a shower, and you would shower, and then exit that room and grab another set of scrubs to put on so that you left the area with clean scrubs. This was our staffing requirements. In the ICU, we had 4 primary nurses who rotated in and out of the room who were in full PPE, including PAPRs, powered air purifying respirators. When our first patient was critically ill, we had 2 RNs in the room at a time and changed them out every 4 hours. Our 2 less ill patients had 1 RN in the room at a time with more frequent changes. We had 1 runner in the ante room for support and observation of anyone who was in the room. We had 1 charge nurse who was at the nurse's station to answer phones, communicate with the team. We used walkie-talkies to easily communicate. When we had more than 1 person, we added 4 more nurses, and we used the same runner and the same charge. When our first patient was on the ventilator, we added a respiratory therapist in the room. Prior to that, the nurses were managing his oxygen needs. And I can't stress the importance of our PharmD, who rounds with us every day on all of our patients every day. Their role was especially important as we used experimental meds and investigational medications on these patients. I'll talk a little bit more about that in a sec. We also had to convert our ER to be able to evaluate patients who might have Ebola. And so we converted a low acuity laceration minor injury area that was a 15-bed area into a 7-bed Ebola isolation observation unit. This is the nurse's station, and as you can see, they put up temporary walls that used to all be open into the patient care areas. In the middle, you can see a window so they could pass things into the area. Nothing came back the other way, but they could pass things into the ante area. And just like upstairs in our ICU, we had a bathroom with disposable scrubs that you would change into, and you walk to the donning area in the middle picture, put on all your personal protective equipment with an observer and a checklist to make sure that everything was done in the right way, in the right order. And then you stepped out into the patient care area, again, one-way flow. This is just the other side of that nurse's station with the temporary wall, and you can see to the left are 2 bays, one in the foreground and one that is harder to see, where the patient care areas were. We have all the equipment that would be used. You can see the Swiffers, which were things that our Emory nurses, colleagues, recommended that we use. Every time a person walked into the area, there was a nurse following behind them, Swiffering with either bleach or some other virucidal towel on the end of the Swiffer. So you didn't have to wonder where somebody walked. They just followed behind you and cleaned up as they went, as you came and went. This is turning the other way. You can see the arrow pointing in is where you walk in. The arrow pointing out is where you walk out. And in the middle picture is the doffing area. Again, there's a mirror, so it's easy to see what you're doing and make sure you don't contaminate yourself. There's an observer watching you doff, and again, the pan for the shoes, and a shower, which I don't have a picture of. It's just on the other side to the right of the scrubs. But the important considerations in both areas, one-way flow. You need to make sure you have an easy way to communicate with the patients, with your staff who are in the hot zone. You need to have adequate space for doffing. You must use a buddy system for donning and doffing, along with a checklist. And that wasn't just somebody with a clipboard saying, yeah, yeah, yeah. Each person, we would sign in, come in to don, sign your name, put in the time in, and you had to check off each step as it was done, and that became part of the records that were kept. As I've mentioned a little bit before, waste is voluminous. There's all the suits, the PPEs that get removed. There's the patient waste, and that accumulates very quickly. It has to be dealt with and handled appropriately, has to be disposed of appropriately, and you have to think ahead of time to make sure that you've planned enough space for all the waste that's going to accumulate. It's part of the reason why that 15-bed area in the ER was a 7-bed patient unit. Some of those rooms were planned just for waste accumulation until they could be appropriately disposed of. All our patients that presented to the ED were screened using the CDC algorithm. As everyone knows, we had 3 patients that were positive for Ebola. They all had or developed the triad of leukopenia, thrombocytopenia, and elevated LFTs. Those 3 patients were moved from the emergency room into the ICU. There were patients who had a positive history using the algorithm of possible exposure. All those patients were evaluated in our emergency room. They had negative lab testing. Depending on their story and their history, they were observed from somewhere between 24 and 72 hours. None of them had, except one, none of them had the classic triad, the lab triad that I mentioned above. One of these patients was somebody who shows up in our emergency room every month or two. She has chronic abdominal pain and mildly elevated LFTs, and she chose the Ebola crisis to present again. There were 30 to 50, my ED colleagues couldn't be sure, patients who were screened and not tested because they were deemed to have no risk. Again, this was all per the CDC algorithm. All those patients were discharged home. The staffing in the emergency room for nurses was 5 RNs for 1 patient, and every additional patient added 2 more RNs. The MD staffing for both areas, and this is not what we started with, but this is what we finished with, is what I think is important to share. We had one of us who was the intensivist for any and all Ebola patients. There were 2 emergency room physicians who came in, whether they were present or not, and evaluated all patients who were possible Ebola patients. There was one of our hospitalists who saw all those patients and admitted them. We had 1 infectious disease specialist, and we involved 1 nephrologist, given our first patient had renal failure. Consumables, I want to talk a little bit about logistics, and there were lots and lots of consumables for our hospital. I couldn't get to the supplies that were used because things that had gone into the hot zone were disposed of, whether they were used or not. So this is the best surrogate I could come up with, and this is the supplies that were purchased for our 3 patients and our 7 possible patients. Almost 49,000 pairs of gloves, 16,000 pairs of high-top shoe covers or booties, over 12,000 sets of disposable scrubs, almost 3,000 full face shield masks, 2,500 jumpsuits, 2,300 N95 masks, 420 PAPR hoods, and 31 PAPRs. And that doesn't count red bags and all the other things, and nuclear wipes, bleach wipes that were also involved. I just wanted to hit the high points. We used some diagnostic equipment, and this is all the things that we used. Once they became involved in our Ebola care, that's where they stayed. So we had a portable X-ray machine with wireless connectivity for plain film. So when we wanted to get a chest X-ray or a KUB, a radiographer tech would go into the room, suit up, go into the room, take the picture, but the machine stayed in our anteroom in our hot area. Each patient in the ICU had an iStat. We have iStats for point-of-care labs. It stayed in their room. It did not come out. And again, our iStats have Wi-Fi connectivity, and we use those for chemistries, INR, blood gases. After consulting with our lab director, there were some chemistries that could be run in a closed system, meaning the machine spins the tube, sticks a needle into the top of the tube, draws a sample, and analyzes it. No labs that require opening, taking off the rubber stopper of the tube to do something with the sample were run and would be run. So again, you need to get that list from your lab director, what you can run and what you cannot run, and you have to deal with it. We had a portable Doppler ultrasound machine that we used to do a cardiac echo and a fast exam in our sickest patient, and we use it for vascular access. We used a CVVH machine, and we used a Puritan Bennett 840 ventilator, which is just one from our usual fleet. We activated an incident command center per our hospital protocol. It was activated on the 30th when the diagnosis came positive, and that was staffed 24 hours a day for 16 days, 10 hours a day for 5 days, and then the phones were answered remotely the rest of the time, and that was closed last Friday. They took over 2,700 calls, and that does not include calls directly to people in the command center, cell phone, or text, which were innumerable. We quickly realized we needed to establish a resolution hotline for people who called in with complaints and comments and concerns to make sure that each of those were addressed appropriately. The Incident Command Center fielded innumerable calls from people with cures. Some were amazingly persistent, and all had to be listened to respectfully and dealt with appropriately. We were descended upon by the national, international media, and we had over 30 news crews with satellite trucks, and all that satellite activity took out our cell service, and we were not able to use our cell phones and communicate with each other. We had to call AT&T, and they placed an emergency cell tower on our campus that is still present today. One Sunday morning when I was sitting in the ICU, about 6 in the morning, someone tweeted the direct line to our ICU, and we were immediately inundated with calls from out of state, out of country. We couldn't get any work done. You put the phone down, it would immediately start ringing, and we had to call telecommunications and get the number changed. And we also had to deal with death threats to our patients as well as our staff. Other challenges is, as you might imagine, it's difficult enough on days when you have a sick patient to care for that patient appropriately and give them the care and attention that they need. Imagine doing that under international scrutiny and having one hand tied behind your back because it's really not appropriate. We did not feel to discuss every decision in real time about patient care, and we could not violate HIPAA regulations. It's very important to realize that evaluating an ill patient in the emergency room or possibly a primary care physician's office who may have Ebola virus disease is much, much different than caring for a patient who has an established diagnosis of EVD. Communication was a constant challenge. There were so many people to communicate with. Within the medical team, there were the nurses, the respiratory therapists, the infection prevention staff, the physicians. There There was the administration, and as you can imagine, this was caused quite a lot of activity and support from our administration, the highest levels, and they all needed to be in the loop. The Incident Command Center was fielding all these calls, and decisions were being made, and sometimes they needed our input. The county health department was obviously involved, the state health department was obviously involved, and the CDC was obviously involved. There were days when, without warning and unbeknownst to us, there was a press conference from county and city officials, county health department, CDC. It was very, very difficult to try to have an effective communication between all the parties involved without being bombarded by phone calls all the time. And staffing is another big challenge. You have to strike a balance between limiting exposure of your staff and limiting burnout. You can see what we did on the prior slides with physicians, and that was done to limit exposure. Given low volumes of patients, that really wasn't a problem for burnout for us, but for our nursing staff, given the number of people that it required to care for these patients safely, that was a big issue. Other challenges, you have to figure out how to deliver good quality, appropriate critical care in a deeply isolated patient. And there are some of the things that you normally do on a regular basis that you really have to stop and think about. Say, okay, now how am I going to, with all this gear on, then put in a central line using appropriate sterile technique? And it can be done safely, you just have to think it through. You have limited diagnostics, as I've mentioned. What goes in the hot zone stays in the hot zone. Dealing with all the waste is a challenge. There's human waste, there's non-human waste, and there's tons of it. The picture on the left, on the right, is the containers that we use to put our waste in. Those are double-walled, heavy cardboard, double red bag lined inside. As you can see, there's a strap on the top that can be tightened down so they're sealed. But those fill up pretty darn fast, and you have to have a plan up front of how to deal with all the waste. We also thought about and came up with a plan of what do you do if one of these patients is pregnant? How do you handle an urgent or emergent surgery in a patient who has Ebola? We had volunteer physicians and anesthesiologists and surgeons who were willing to be on the ready if we had a patient with Ebola who needed emergent surgery. They would have done this in the room, and obviously that limits the procedures that could be done. These are not patients to take to the operating suite.
Hey, Gary.
There's huge psychological challenges, and it's very important to address mental health early. The mental health of the patients, they're terrified. They're very ill. They've got a potentially deadly illness, and they know it. And it's very important to help them deal with their fears and their emotions. Our other patients had fears, as you can imagine. They were worried, are they somehow going to get this disease because it's anywhere in the hospital? The staff, our nurses, all the care team had all the same fears that non-hospital personnel have, only they were more informed, but they were still afraid. And then the family of the patients, the family of our staff, they had to deal with this as well. So it's really important to try and alleviate fear of the unknown. That's a difficult task for all of us. Someone sent me this picture on the left. This is from an airplane. If it doesn't project well, that's a woman seated in her middle seat in the airplane with her mask on, her gloves, and goggles. And how do you address the community fears and perceptions? How do you give them the information that they want and need without violating the rights of your patients?
Hey, Gary.
There were unintended consequences. As this went on, we had increased call-ins of our staff, and that's just the reality. Again, in our efforts to limit the number of staff that were exposed, the staff that were present were getting tired. Their family was getting tired. It had effects on our loved ones, our patients, our staff. Things as trivial as the housekeeper won't come or the yard guy won't come to the house, to our nurses and staff's kids being sent home from school because they were worried that their kids were going to infect somebody. We had the husband of a friend of a nurse who got sent home for 3 weeks and furloughed by his boss and said, "You can't come to work here for 3 weeks," because of unreasonable fear. Our staff is furloughed for 21 days past their last patient exposure. And the reason I'm not present at the convention center giving this talk is because I'm furloughed from patient care and being in public places for 21 days past my last patient encounter. So it's very important. I don't want to say to make this seem like I'm unhappy or bitter. This was an unbelievable opportunity for all of us, and there are some things that we can try and do to mitigate exposures. You should consider video evaluations of patients who are less ill. Is it a patient who's not ill, who's being seen by the nurse? Is it necessary for the physician to actually go in the room every day? That's for you to decide. But we tried to limit the visits. We came up in our less ill patients with a schedule so that one physician a day examined the patient. Everyone else picked up the phone and talked to them, or FaceTimed or Skyped with the patient so that they could see how they're doing. But we didn't think it was necessary for every physician to go in the room every day. The nurses need to be cross-trained for extra roles that they'll do. The two big ones are cleaning. Our nurse colleagues from Emory said that that's what they do the vast majority of the time. They're constantly cleaning. They're constantly wiping down the counters where everybody walked. Somebody walks in and walks out, they clean with the Swiffer. They're constantly cleaning so that you're trying to minimize any potential exposure to anyone and everyone. You need to have point-of-care lab testing so that you can get labs with a minimum risk to personnel. And again, one of the things that we learned from our Emory nurse colleagues was when you have liquid waste, that's important to solidify it. And there are solidifiers that your GI lab should have present right now that work great. So how do you do this in a community hospital from a big picture? This is my opinion. You need to create a volunteer medical team. You need to identify who's needed on that team and clearly just explain and model out job descriptions. You need to try and figure out how to establish seamless communication capability and not just chain of command, which everybody is pretty familiar with, but it's also important to have chain of communication. Who needs to be aware of what and when? And that was not quite as well thought out at the beginning. It firmed up as we went because it had to. There needs to be an informational flow. Everybody needs information. They don't all need all the information at the same time, but it's important to figure out how to flow information and to debrief on a regular basis. The medical team, hospital officials, the non-hospital officials. And then early on when you're interacting with people that you don't interact with on a daily basis, like for me it was the people, the personnel from the CDC, it was the people who were running the Incident Command Center that I've kind of heard names but don't really know who they were. Up front, everybody needs a printed sheet or an email with everybody's name, their contact info, their cell phones, and what their role is, so that at 4 in the morning when you need to contact somebody, you can go straight to them and don't have to try and figure out how to find the person you need. The role of the pharmacy is huge, and I alluded to it. There are tremendous logistics involved with giving experimental therapies. You have to have an IRB, and if you don't have one, they can be formed emergently or you can use others. You have to get FDA permission. You have to get permission from the drug company. You You have to get an emergency investigational new drug application signed to use these experimental meds in an emergency basis. And then finally, you have to locate the drugs. These meds are not in your hospital formulary, most likely. And they're certainly not at the CVS. So you have to locate them and get them. You have to have a place to keep them that is safe and secure. Clinical collaboration is huge and was greatly helpful to us. Obviously, this was something we did not have experience with before. And as I mentioned, we had at least one call a day to talk about the patients, and we could call at any time that we wanted to or needed to, and we collaborated with Emory, the CDC. Nebraska is a good resource, and I would argue that we now have some experience and have things to share. I think this is really important, and this is why I wanted to give this talk and why I'm giving this talk. And this quote has been attributed to President Truman, but it was just not his quote. It was a favorite quote of his, as well as Coach John Wooden. It's what you learn after you know it all that really matters. So I think what we do with this information, how we spread this information and communicate it to all the other community hospitals that at some point may be dealing with these kinds of patients is what really matters. And as I told you at the beginning, this was a story about journeys, and I'd like to finish with where I think our journey is. Because it's Texas, because it's the end of the football season, and because my son's high school team is going to the playoffs this weekend, and I've got KU up there for Dr. Simpson and myself. My analogy is that we caught this kickoff very, very deep in the end zone, and we started running the ball up the field. And I don't have a clue where we are in this process, how far up the field we are, but my hope and desire is that as more centers, more hospitals get experience with these patients, that we will all collectively continue to move the ball up the field and score a touchdown and do a great job with Ebola virus disease as we've done with every other medical challenge that we've been faced as a medical community. And with that, I will stop.